Good evening, everyone, and welcome to this joint webinar organized by the section of pediatric neurosurgery and functional neurosurgery section of ENS. I'm very glad to have here Olaf Scheens, who is the chairman of functional section, and his co-moderator Daniel Nilsson. I really hope that you will enjoy this webinar with these exciting topics and exciting talks. And I pass the word to our moderators. Enjoy.
Thank you, Radek, for the kind introduction. Welcome, everybody, in this next webinar series of the sections Functional Neurosurgery and Pediatric Neurosurgery. We will have a talk with distinguished European speakers. The theme is Epilepsy Surgery in Children, Level 1, or basic level, as you want, because us reached a lot of questions to have this topic in a webinar. We found three distinguished speakers. The first of them is Dr. Gwendoline de Bruin. She's a pediatric neurologist in the Epilepsy Expertise Center Copenhagen in the Netherlands, working together with my hospital in Maastricht University Medical Center. Please, Gwendoline, for you the words.
Okay, just a very short on housekeeping. So we'll ask the participants to use the Q&A button for questions, because we will have 3 speeches which are about 15 minutes each, and at the end we will have about 15 minutes for questions. But please use the Q&A button, which is at the bottom of your screen on Zoom. Thank you. Please, Gwendoline.
So good afternoon, and thank you for the invitation to speak today. My subject is non-invasive preoperative workup. I'm a child neurologist in Copenhagen, and as we all know, epilepsy surgery in children and adolescents is unfortunately still underused. So we still have a lot of goals and opportunities. I will present a case in order to explain you how we handle patients and have structured it. And I'm very happy to hear if you have other inputs, how you organize it in your center. So the first case is a girl I got to know at the age of 11 years. She is right-handed. She had a typical febrile convulsion at the age of 9 months, and her epilepsy started at the age of 9 years. Her seizures consist of sudden swallowing, orofacial automatisms in her right hand, some flushing, loss of contact, and post-ictally, she's soon adequate again. She does have an amnesia of the word that the nurses tell her during the seizure, and she had some nose wiping on the left. So for me, this semiology points more to a temporal lobe onset. She was on 2 drugs, and she still was having frequent seizures. And at referral, her MRI was supposed to be negative. So how do we start the evaluation? We have different phases in this trajectory, and we start with phase 0, which means that we do an intake together with the nurse practitioner, and we tell parents how we're going to start the evaluation, and we have a structured questionnaire where we gather all the information that we need. And we noticed that it's very important, even if kids are young, it's important to take them through this process. And so recently we made an animated video to also let them take an active part of this evaluation. Then we proceed to what we call phase 1, which consists of video EEG monitoring, a neuropsychological evaluation, and a 3T MRI of the brain. And so we also did in this girl. This is our monitoring unit at Kempenhagen, and what we think is very important is that there is also the possibility for patients not to be fixed to their room all the time, but they can be in this big room where we have video monitoring, and our nurses keep an eye on them also on the EEG all the time. For this case, this is the EEG. So I put an arrow so you can see the left frontotemporal sharp waves that we see interictally. She had several seizures, and important is that the semiology they mentioned is the same semiology that we see during the monitoring. And we see that the seizure starts on the left frontotemporal region, and it evolves and spreads in the rest of the left hemisphere. What we also see that it takes some time. She keeps on talking and doing some things, and later on in the seizure we see that she loses contact, and here you see that it keeps on evolving, and then the seizure stops, and we see a post-ictal slowing also in the left frontotemporal region. So that was the video EEG monitoring, and then what is very important is that we perform a MRI that is 3T and also an epilepsy protocol. And our nurse practitioner is also doing a lot of efforts to prepare children to go in an MRI to have a good quality. This is the MRI of our patient, and you can see that the left hippocampus is smaller on the T1, and on the T2 we see that it's also hyper intense. And then we went to our epilepsy surgery work group with the video EEG monitoring results, the MRI results, and the neuropsychological evaluation that showed that she has problems with long-term verbal memory. And so our work group decided that she could be a good candidate for a temporal lobe resection. And in this case, we particularly decided to do a selective amygdalohippocampectomy on the left side. And so this is the post-operative MRI, and actually now she's almost 1 year after surgery, and she became seizure-free immediately after surgery, and she is still seizure-free after reduction and even stop of the anti-epileptic drugs some months ago. So this is a very nice result. And then I wanted to point out that it's important to look at the MRI. And in this patient, for example, the MRI was supposed to be negative, but we had a second look and we did a new MRI. And we see that in patients that have a lesion or histopathological difference, that they have a better outcome after epilepsy surgery. Of course, you have to be sure that the lesion is the source of the epileptic attacks. But of course, we also have cases in which the MRI is truly negative, even if you perform voxel-based morphometry or you perform 7T MRI, and then luckily, we have additional imaging techniques that we can use to evaluate the patients. And here you can see if for a temporal lobe case, we usually advise a PET scan, an FDG PET. And if you find hypometabolism in that temporal region, then you can also proceed to a temporal lobe resection. In extratemporal cases that are MRI negative, we use the PET scan, but we also use a SPECT, which is a technique where you admit patients, they have an EEG, and you actually inject a tracer. It's very important as soon as possible when the seizure starts, and then you do a scan, and then you also perform an interictal SPECT where you also inject the tracer, and then you do subtraction of the images, and you see where there is an hyperperfusion. Like in this case, it's a left occipital case. We also use MAG, which means magnetoencephalography. And this technique you can use, it's some kind of an advanced EEG where you can look at deeper sources and especially at spikes that are oriented interhemispheric or more peri-sylvian because they have a different orientation. You can also use EEG fMRI, which means that you need a lot of spikes because you do an EEG and you look at the time of the spiking, how the oxygen use in the brain is. And then for cases where you are concerned about language, for example, you can do also functional testing. For example, a functional MRI to see what is the lateralization of language. And like that, you also gather all this information and you go back to the epilepsy surgery work group and we decide whether we find results concordant and we can proceed to often an SEG procedure, for example. And I'll also have another patient just to extra illustrate this extra workup in MRI negative patients. And she is a girl of 15 years old. She's also right-handed. She had epilepsy onset at the age of 7 years. Her seizures were very particular because she had auditory stimulus, like, for example, her dog that was barking, that was giving her a lot of seizures, and also a tactile stimulus. And then she proceeded to tonic posturing, some clonic movements on the right side, heavy breathing, big eyes, hypersalivation, sometimes urine loss. And a lot of times this evaluated to a tonic-clonic seizures, and particularly she had a lot of clusters of seizures, and she had to be admitted at the emergency unit and intensive care. So this had a huge impact on her life. She had tried several antiepileptic drugs, but there was no improvement. If you look at this semiology, it's different than the first case because there you had more like a temporal sense if you think about the semiology, but here it's more like extratemporal, and her interictal and ictal EEG pointed to left frontal central region. In her case, because we also performed genetic analysis and that was negative. And she had an MRI, and we did the VBM, the voxel-based morphometry, and still we could not find a lesion. So she also had these extra imaging techniques. And in her case, especially ictal SPECT pointed more to a mesial frontal and SMA region, and the MEC was more like dorsolateral. And then if we put everything together, semiology, video EEG, and the extra imaging techniques, we still had a broad hypothesis, thinking especially about left mesial frontal, perisylvian insular, and periorlandic. And so she was also discussed in the epilepsy surgery work group, and there was decided to do a stereo EEG implantation. And in her case, her seizures started in the anterior cingulum region. And so there was a radiofrequent thermocoagulation performed. And after that, she had several months, she didn't have any seizures. She was, of course, still on her anti-epileptic drugs, but that gave a good prognostic value to perform a resection of the anterior cingulum. And now, this girl is still in follow-up with me, and she is seizure-free, gathering her life together again, and she has already a lot less anti-epileptic drugs than she had before. So if we think about the important messages after this presentation, for me, when I started, it was very important to have this structured analysis to see whether a patient can be a candidate for epilepsy surgery, taking these different phases and steps and discussions in the epilepsy surgery work group. It's important to look carefully at your MRI and preferably together with an experienced radiologist. With the information of the semiology and video EEG monitoring, and go and look for the lesion and do your very best to find it. And of course, after that, you have to be sure before going to surgery that the lesion is indeed the source of the epileptic seizures. If your MRI is truly negative, you should do extra investigations, and it's important if you want to proceed that there is concordance of the different modalities. And an epilepsy surgery work group is very valuable to have multidisciplinary discussions to come to a good advice, I think. Okay, I don't know how fast I talked, but this is what I wanted to tell you today.
No, exactly. That is, it was within the time. Thank you very much. Very interesting. I think especially for beginning centers, this is worthwhile information. I see in the Q&A box, there is a question for you from our digital audience, Matthias Tomczyk. He is asking, are all patients allowed to move around freely? Or are you more cautious in patients where you would decrease the anti-seizure medication and patients with known drop attacks?
Yeah, so I think you have to be cautious if your patient is known with tonic-clonic seizures, but we try to give patients freedom to move in this unit. So they are not locked in their room, but of course you have to have some you have to be alert, and especially you follow up the EEG constantly. So if you see that there is subclinical seizures or the buildup of the interictal pattern, then of course we keep an extra eye.
Exactly. The second question I see from Mana Al-Qaddafi. He is asking if you make an MRI without contrast.
At first we do, of course, if you find a lesion, then we do an additional MRI if you suppose that there might be a tumorous process.
Exactly. So, but the harness protocol, the European protocol by the ELAA adopted, is without contrast in first instance, but you can then adapt it to contrast when you think about indeed a kind of tumor.
Maybe, Olaf, should we go on and take the next talk?
Yes, I see just one last question. I think that is Dirk van Roost from the Medical University in Ghent. He asks Gwendoline, does, in your opinion, the epileptological pre-surgical workup basically differ between adults and children?
We do the same investigations, but I think that still that children, adolescents, and grown-ups are different in a lot of in the decisions we take. Maybe I don't know whether that's an answer to your question, but yeah, that's how I feel about it.
Great. We can discuss afterwards, perhaps.
Yeah.
Please, Daniel.
Okay, so our next speaker is Yugoslav Ivanovic, who is a consultant at the National Hospital for Neurosurgery in Oslo, Norway, and is doing a lot of epilepsy surgery. Please, Yugoslav.
So you can see my screen, yes? Thank you very much, Daniel, for a kind introduction. and for invitation to this webinar on pediatric epilepsy surgery session. So I will give a talk on invasive EEG recording. And as you said, I work in Oslo, Rikshospitalet. This is a National Center for Epilepsy Surgery in Norway. So we treat both epilepsy patients who are adults and children, these who are drug-resistant with drug-resistant epilepsy. So we perform approximately 50 resections and 20 to 25 stereo EEGs each year, so 1/3 of this on pediatric population. So in the beginning, when I started my epilepsy surgery fellowship in 2007, so we performed, implanted a lot of subdural grids and strips, and since 2015, we completely converted to SEEG. And my talk today will focus on this mainly. So this is my disclosure. So for us, SEEG, it was a game changer in our epilepsy surgery practice because since introduction of this method, we could treat more complex epilepsy patients. So all of this started back in 60s when Talarak and Bagho, they developed the technique of placement of depth electrodes in the brain parenchyma for EEG recordings. So later on, this was disseminated knowledge and with technical development, so it became more accessible, and today it's used in most of these epilepsy surgery centers in the world. So it has to be mentioned that this is an advanced stereotactic procedure in which multiple electrodes are implanted through small craniostomies using either a stereotactic frame or some of these frame stereotactic systems. So when do I use it in practice? It's when we need to confirm or reject our working hypothesis on the epileptogenic zone in epilepsy patients when all other investigations did not give us strong arguments to proceed with surgery. This French group has proposed guidelines where they address many aspects of SEEG, from indications through surgical planning and techniques to interpretation of SEEG and radiofrequency thermocoagulation. And SEEG is well suitable for exploration of deep cerebral structures such as medial aspects of the brain, insula, periventricular regions, depth of sulci. When we see a lot or when we see nothing on MRIs, and in cases we do multilobar or bilateral explorations. And we often perform after failed epilepsy surgery. So it is not only a diagnostic, but also possibly a therapeutic tool, and using electrode contacts for radio frequency thermocoagulation is possible. So this was presented 10 days ago on ESTM webinar, which is available online, so you can see it. So why did we shift to SEEG? So it is because it's obviously less invasive when you compare with the subdural grids that require a large craniotomy, and therefore it is better tolerated by children. It can give us precise spatial and temporal information on seizure onset zone, as well as it can be easily correlated each of these electrode contacts to the anatomy, which was presented in this table where we see on the left side the electrode name, and going from left to the right, from deep to superficial contacts. So also in contrast to grids, there is no need for prompt EEG analysis and resection at the time when the electrodes are removed. So our neurophysiologists can have more time to make conclusion. So what do we know about morbidity and complications? And is this procedure safe? So this meta-analysis showed that SCG has lower rates of C-cyst leakage, hemorrhages, infection complications when you compare with pseudoradrids. And also that patients who were explored by SCG, they have better chance of becoming seizure-free after resection. This publication showed that up to 20% of patients do have any type of bleeding seen on a CT, postoperative CT scan after SCG. So few of these resulted in permanent deficit or death. And another meta-analysis also confirmed low rates of morbidity and mortality after SCG. So this is concluded that it's quite safe procedure. So now I'd like to share some thoughts on the technical features in SCG. And this is one of few occasions in medicine you can say that children are actually small adults, because SCG implantation is based on a universal three-dimensional coordinate system. So in frame-based procedures, so the stereotactic procedure, that angular error at entry point do not affect the precision at the target point, while in contrast, in frameless ones, small angular error at entry point may affect accuracy at the target point. And here we can see that the bigger angular error and the longer trajectory you have, so the higher target point in accuracy you can get. And like other stereotactic procedures, SCG is prone to sources of error, which may depend on many factors which are illustrated in this publication. So these may be either hardware, software, patient or surgeon dependent, and are very usually difficult to recognize. So therefore it is important to optimize and standardize your surgical workflow to be able to detect these errors. Because what do you want to see? You want to get this postoperative image where all electrodes are on the spot of planned trajectories. And you do not want to get this where you see a systematic deviation of electrodes when compared with planned trajectories. So this serious mismatch, which can be hazardous, it appears due to the error of the inpatient registration, which was earlier what we used surface matching. That was our method when we matched the surface of the patient to camera and the system. And this did not allow us to check the precision of the registration. So why do I talk so much about error sources and why are we so concerned with the precision? It is because the most of serious hemorrhagic complications that are described in literature, they occur at the entry. So the place where the drill goes through tabula interna and the electrode goes through dura. So therefore, when I plan trajectory, I always count a radius of 3 millimeters as a safety margin around the plan, and which is indicated in this ring. And in this ring, I really do not want to see any of vascular structure. And this slide may illustrate why we need safety margin. This is a frontotemporal insular SEG exploration. The red line represents the plan for trajectory for posterior insular electrode. And if we focus on the sagittal and axial plan, at the entry point, we can see almost 3 millimeter deviation of electrode in posterior direction, which fortunately did not hit this big vessel. So therefore, we encourage all our colleagues to perform own quality checks on a regular basis. And this is how we do it at the entry point of the target. And then I plot these extracted XYZ electrodes, coordinates for both electrode and the plan, which are then subtracted, and the difference what we get using Euclidean equation we can get exact 3D deviation of the electrode at entry and target points. So after processing all the electrodes, I get a chart that indicates the precision of the session. In this particular case, the system took a little bit in front and below, which at entry point, which is presented with these red dots. Although you can appreciate that 50% sorry, of entries are within a radius of 1 millimeter. So target point accuracy in few millimeters, it is less relevant, both when you think about the complications and the epileptogenic zone exploration. So our patient workflow goes like this. Patient is selected at MDT meeting. Outpatient CT scan is acquired, which includes CT angiography with venous phase and subtraction to eliminate the bone, which exposing better this small vessel just beneath the bone surface. Also, we acquire MRIs for neuronavigation. And 1 week before surgery, we do a pre-implant MDT meeting where we agree on the patient-specific exploration plan. So you should keep in mind that SEEG is not standardized, but highly tailored exploration and unique for each patient. So with surgical planning, I fuse images together, transfer this plan to the software, and then I see that use MRIs for anatomical targeting while CTs to avoid vasculature. So since 2021, we use intraoperative CT for auto-registration of SEEG patients. And this is how our OR setup looks like with neuronavigational tracking system and sterile reference array that is attached to the head clamp. We routinely place bone fiducials, which I'll comment in the next slide. And then we acquire auto-registration and CT scan. And these red rings indicate attachment place for the stereotactic instrument. So when we have taken the CT scan, I validate the registration by pointing on bone fiducials because these are the only anatomical landmarks that I had. So this may detect the registration accuracy in anteroposterior, medial, lateral, and rotational plans. And after that, I perform surgery with perfectly aligning this stereotactic device. And on post-CT, we see for complications and position of the electrodes. After surgery, patient is transferred to neurosurgical department for continuous observation, and it's given intravenous antibiotics, and medicines are removed, usually for first post-operative day. So when patient had enough seizures, a neurophysiologist, they perform stimulation study. So when we are done with everything, under general anesthesia, we remove electrodes and we obtain another CT scan the day after before the discharge to the epilepsy hospital. So within 2 to 3 weeks, neurophysiologists present conclusion on SEEG, and if surgery is indicated, the patient is appointed. A little bit about our experience. In past decade, we have implanted more than 2,000 electrodes in 175 patients. 4% of these, they have 2 implantations. And this diagram shows the frequency of electrode contact points we use. So in our patient cohort, there is equal ratio between male and female sexes. Around 1/3 performed in children, and 75% go to resection after ECG. And those who do not go to resection, it's mainly because epileptogenic zone interfered with eloquent cortex, or our hypothesis was not confirmed. And these charts here, they show average number of electrodes used per surgery, and the average time of electrode implantation that reflects the learning curve. Using an intraoperative CT scan for auto-registration, we have improved the electrode accuracy of both entry and target when we compare it with surface matching. And this is also further supported by our calculations, where we can see significant difference in favor for auto-registration. These charts, it shows that most of our electrodes are within 2 millimeter radius from the plant of both entry and the target. And lastly, these are our complications of first 100 patients. Hematomas were asymptomatic, did not require surgery, while this osteomyelitis that was caused by one bolt, it needed surgical revision. So I always encourage my younger colleagues to exercise SEG on phantoms, which requires an extra effort. However, they know that practice makes the master. And to wrap it up, I would say that SEG is a useful modality for exploration of the epileptogenic zone in drug-resistant patients. It is well-tolerated and safe procedure used in both adults and children with low rates of the post-operative complications. SEG gave us possibility to explore and potentially offer surgery to more complex epilepsy patients who would earlier be rejected from the resective procedures. So to avoid complications, use your time for planning, standardize your workflow, and get know to your instruments. And considering radiofrequent thermocoagulation through implanted depth electrodes, you may use full potential of SEG both as a diagnostic and therapeutic tool. And with this, I would like to thank to my colleagues and to you for your attention. Thank you very much.
Thank you, Yugoslav, for this very comprehensive talk. So what do you say, Olaf? Should we go on directly to Christian? So we are...
Yes, I think we are on time. We should go on. I see questions in the Q&A box, but these are questions for Gwendoline de Bruin. So there were no questions at the moment for Yugoslav. Perhaps we can do that at the end when there come more questions.
That's great. I will ask you, Olaf, to keep an eye on the questions and also because I cannot see them for some reason. So I want Christian Dorfer, who is a professor in neurosurgery, consultant neurosurgeon at the University of Vienna and also National Hospital in Vienna. And he also is a president for the International Epilepsy Surgery Society, which is a newly formed society, which is a really nice forum for neurosurgeons into epilepsy surgery. So please, Christian.
So can you see my screen?
Yes.
Here you go, right?
Yes.
Okay. So yeah, thank you very much for the opportunity to share with you some thoughts about resective surgery in temporal lobe epilepsy in children. So this is going to be my agenda. So addressing what options we have, then discussing the pivotal question, what is the optimal extent of resection, and lastly, my personal experience on the differences from the surgical perspective between children and adults. So what surgical options do we have? So this is a temporal lobectomy, so which is generally assumed to be on the non-dominant size 6 to 7 centimeters, measured from the tip of the temporal pole dorsally, and in the dominant hemisphere, it's less, it's 4 to 4.5 centimeters, which is also differing between centers and between surgeons, but this is generally the concept. And then we have the so-called anteromedial resection, where you just resect the tip of the temporal pole, sparing T1, which is then the so-called Spencer technique. And then we have selective medial resections. And for the selective medial resections, there are a lot of options. So you can do it transcortically through T2, or you can do it subtemporally below the temporal lobe, or you can go through the Sylvan-Fisher, as you can see here. And here's the coronal section addressing all the different ways to the mesotemporal lobe. So the question now is, with all these options available, what is the optimal extent of resection? Which approach should we choose? So in general, the direct comparison of these different techniques and resection volumes is difficult because first, most centers have specific indications for specific methods. Most of the comparisons are performed and compared with historical case series. And last but not least, in the large pediatric case series are still limited. So when we ask the question, what is the optimal extent of resection, we should ask, what is the current practice in pediatric temporal lobe epilepsy? And I am showing to you this nice paper from the Bonn group, which is also a nice literature review. And here you can see that they gathered together over 2,000 pediatric temporal lobe patients. And in this group, over 50% of them got anterior temporal lobe resection. Only 27% had amygdalohypocampectomy and lesionectomies. So the vast majority apparently is doing anterior temporal lobectomy in pediatric temporal lobe epilepsy. What about the adults? So in the adults, you see this forest plot here. Everything which is on the right side here shows you that in this series, anterior temporal lobectomy is favored compared to selective amygdalohypocampectomy. So in this systematic review, again, anterior temporal lobectomy in adults was favorable. And also in this systematic review, also in 2013, they compared transcortical selective versus anterior temporal lobectomy, transsylvian selective approaches versus anterior temporal lobectomy, and also multiple approaches. And also in this review, anterior temporal lobectomy is in favor compared to selective approaches. So what about children? So again, the largest experience at this time from the Bonn group. And this is the conclusion for the different types of resection in pediatric temporal lobe epilepsy. So the results after selective amygdalohypocampectomy were disappointing. So before going into detail about this notion and also the follow-up study on this, we asked the question, what is the optimal extent of resection of the mesial structures? So let's start with the hippocampus. So what we know from the adult world, at least, and this was this randomized trial by Johannes Schramm, addressing 2.5 centimeters versus 3.5 centimeters in resection of the hippocampus. And this is the result at 1 year. Seizure outcome did not differ between these two groups. So the conclusion here is it didn't really matter. Another option is to do it with electrocorticography, as suggested by George Ogerman. And in this series, all patients that had postoperative electrocortical epileptic formic discharges had a significantly worse seizure outcome. But not many centers today, at least as I'm overlooking it, are using this interpretive tool for given reasons. And then what about mesial cortex resection? So the mesial cortex in temporal lobe epilepsy, we are talking about the temporal polar cortex, the piriform cortex, the perirenal entorhinal cortices, and the posterior parahippocampal cortex. So with this question, we need to discuss this paper, which is again from the adult world, but very important because there came a lot of discussions out of it. What they did is they took their temporal lobe epilepsy patients and did a very nice volumetric calculations. And what you can see here, SF is seizure-free, NSF is non-seizure-free. And they calculated differences between hippocampus, amygdala, entorhinal cortex, and over-resection volume, and they didn't see any difference in these kind of calculations, but only the piriform cortex. But this to say, there are no recent publications that have really confirmed these notions, and it's still causing a lot of discussions. And it's not new. So back in 2007, the group from Fernando Sendes also did something very similar. You can see here they calculated amygdala, entorhinal cortex, hippocampus, parahippocampus, and in their conclusions, as you can see here, entorhinal cortex was very important, perirenal cortex was very important, and amygdala was also very important. So in summary, we can say that all of these cortices are critical to include in the resections, and in the end, it's difficult to not resect the entorhinal and perirenal cortices without resecting the amygdala, and vice versa. So these cortexes seem to be critically important also in children, but there's no evidence of any difference between adults and children. It's just because of the low case volume, I would say. But nowadays, we also need to discuss new entities in terms of our way to understand epilepsy and evaluate epilepsy. So nowadays, we have tools like epilepsy lesion network mapping, as in this paper here, where they calculated the epilepsy network before surgery, and then what remained and what was removed, and then calculated the results of this. And what you can see is patients that had a good outcome had a low abnormality in their nodes, and patients with a bad outcome had a high abnormality of their epilepsy nodes. So this is something which is for sure becoming more and more incorporated in our evaluations in the future. But coming back to the children, what outcome can we expect in children? So again, the Bonn group. And as you can see, the outcome that we can expect is very, very good. So this is outcome until 2 years, over 80% are seizure-free. It is decreasing over time, as in all of our temporal lobe epilepsy series, in adults and in children. Over time, the degree of epilepsy seizure-free patients is decreasing over time, which we don't really understand so far. And then, which is very important in this paper, in the discussion sections, by becoming more selective in which patients underwent selective resections alone, while not improving the overall seizure freedom, we did improve the results of selective resection from 74 up to 86% in the recent patients after 2001, which is very important, I would say. So it's a matter of selection in the end, and if you are very precise and stringent in your selection, you can also harbor very good seizure outcome rates with selective resections. And what is the problem with selective resection? There is the issue of dual pathology. So this is a very old study dating back in 1991, but this is a very important one. So here they addressed mild cell loss and severe cell loss within the hippocampus, and then investigated in 180 patients where other pathologies have been found. And as you can see, especially in this graph here, so they even distinguish between the different components of the hippocampus and the cell loss. And what you can see is this is the cell loss in hippocampal lesions only. And if you see heterotopia, as they called it at this time, severe cell loss in the hippocampus is associated also with heterotopia, so focal cortical dysplasias, apparently, and also other pathologies. And more recently, and this is coming out from the Cleveland group in pediatric temporal lobe epilepsy in 2012, also here, as you can see, MTS, mesial temporal lobe sclerosis, 30% had an associated focal cortical dysplasia. And also in this series, the type of surgery, so lesionectomy plus So here it is called corticoamygdala hippocambectomy. So this is temporal lobe resection. They did better because of this dual pathology. And also in this series, one very important message, I would say. This is coming out from the University of Alberta. So in this series of pediatric temporal lobe patients, anterior temporal lobectomy did far better than selective resections. And if you go for a re-resection, you can also see here that anterior temporal lobe resection following selective resection, they were able to achieve angle class 1 outcome in 7 out of 8 patients, which is a lot. In contrast, if they extended, did a resection in patients that already underwent anterior temporal lobe resection, only 1 got seizure-free, which is an important message, I would say. So the question is, why should we be more selective? So the hypothesis is, if we do less, then we do less impact on the neuropsychological outcome. But this to say, the assumed reduction in the risk of selective surgery-related neuropsychological deterioration did not unequivocally stand the test of time. So it wasn't ever really confirmed. And this is because it's very, very difficult, because you know, in children, you have the different types of developmental stage. Then you have the influence of duration of epilepsy. You have an influence on dominant, non-dominant. You have the influence of how was the patient doing before surgery. So many factors that are contributing to this analysis. And also the question on what tests are you applying. So this is a very good study done again from the Bonn group. And what you can see here is, or what the conclusion here is, to summarize it, that Transilvanian selective approaches are favorable in the right and temporal lobe resection in the left mesotemporal lobe epilepsy, which is counterintuitive if we want. So the left would be the dominant. So I would say people would be more willing to do selective resections in the left dominant than in the right. So this is to show you that it's very critical and very complex what you test, what patients you include. And this is why this question has not been yet confirmed so far. And then there is LIT. You know, in the US, open resection for temporal lobe epilepsy are literally dying. And LIT is apparently a game changer in this discussion, because nobody in the US is discussing, should we do an anterior temporal lobe resection or a selective resection? It's all about LIT. LIT is a selective ablation procedure. So here you can see that the method itself is triggering the question and the discussion around it. And we will see how this is changing the landscape in Europe. I would say it's not going to be the same, but for some indications and centers, it will be of influence. And you can especially address those patients that do not want to have open surgery. And this is the gap that we can have and address with the LIT technique. And last but not least, for the last seconds, my personal experience in surgery between children and adults. Of course, in children, everything is thin, which is obvious, but it can make your surgery very, giving you a hard time in adults if it's a large flap, and very nice in children. The bony anatomy in children is somewhat different, so you need to have experience with that and address that. Of course, in children, head fixation can be cumbersome, so you need to address this. In the opposite, in adults, if they are large and broad shoulders and a short neck, patient positioning can be cumbersome. In infants, especially, the brain is vulnerable, so whenever you touch it, you can cause some damage to it. Sometimes the subfield dissection is not that easy in children, especially against the Sylvian fissure, at least what I have experienced so far. And of course, in children, all of the setup of the anesthesiological demand, the operative care is very, very different. So this needs to be done in centers that have experience not only with epilepsy surgery, but also with a child surgery and epilepsy surgery in children in the whole. And many of the things that I have told you and much more details you can read in this book, which will be released on July the 1st. And here is a chapter from myself addressing many of the questions that I have discussed. And with this, I thank you for your attention.
Thank you, Christian, for this wonderful talk. So Olaf, do we have some questions you will select?
Yes. Perhaps I will go on where I stopped after the last lecture. Let me see. Well, there is a question for Dr. De Bruin. Thank you for your insightful presentation. Are there any potential risks associated with epilepsy surgery in children?
Maybe that question should be forwarded to the surgeons.
I think so, yes.
The short answer is yes, right? There are risks.
Who wants to discuss this? Yugoslav or Christian?
I'm sorry, but I missed the question.
Are there any associated risks with epilepsy surgery in children?
In children, yeah.
Compared to adults?
Yes.
I would say the biggest difference in surgeries between children and adults is the postoperative phase. Because in children, children get a lot of pain medication and they are very drowsy. So neurological surveillance is much more difficult than in adults, I would say. So whenever you may have a problem, it's much more difficult to decide this on a clinical basis than in adults. So I would say for the postoperative care, this is something different. And for the surgery itself, as I said, in very small children, at least in my experience, the brain seems to be more vulnerable and more prone to bleeding. So this is for sure a risk that needs to be addressed and discussed with the parents beforehand.
Yeah. So in this respect, when we look worldwide, I see many epilepsy surgeons treating both adults and pediatric patients. So not a specific pediatric neurosurgeon doing the epilepsy surgery, but the neurosurgeon who treats the adult patients also in general treats the pediatric patients. So do you think there is a kind of threshold age where you see really differences? For example, epilepsy surgery before the age of 1 year in respect of blood loss and positioning, no possibility of head fixation. Do you think there is a kind of threshold age where you would say there is a real difference in technique?
Yes, definitely. So if you're used to operate on adults, then teenagers are not really different, right? Because they can sometimes have more weight than myself. But then if you come to smaller children and you are doing surgeries in children not on a regular basis, it can become stressful for yourself because the patient positioning and head fixation is very different. So you need to feel comfortable, because if the patient positioning and a head fixation is putting you under stress already, then surgery might be difficult from the starting point. And with regard to a cut-off age, I would say everything below 3 years of age is different from many aspects, because in this age population, blood loss intraoperative becomes more and more critical. And if you are not used to, precise control of your blood loss, then this might something be that should then be done by someone who is doing pediatric neurosurgery on a regular basis, and especially below 1 year of age. So if you are not doing pediatric neurosurgery in children below 1 year of age, I guess it's not a good idea to do your epilepsy cases every once in a while coming from the adult world.
I can also maybe comment there, or Yugoslav, if you want to comment for SCG, there are specific challenges, I think, in very young children with the bone thickness and so on. Would you comment on that, Yugoslav?
Yeah, I can do this. For SCG, in our youngest one, I think it was around 2 years of age. So when you see, in general, temporal bone in adults is thin, and then you can imagine how thin it is in pediatric cases. So the thing is, if you need to explore these regions in pediatric patients, then it's very difficult to attach the bone screw, this bolt through which the electrode is placed. You have to be very careful about that. You shouldn't put too many of electrodes nearby each other, not to destroy the skin in general. Then fixation of the head, as you mentioned, Christian, it is sometimes challenging, but this can be a little bit troublesome, as you noticed.
So, Yugoslav, would you have a lower limit of bone thickness for your SCG procedure?
I tried to put it to 2 millimeters. I think that the thinnest one was something like this, and then you have to you shouldn't screw all the way through. You should find some balance just to hold and not to deviate, and then if it is not well attached to the bone, so you can always make a suture outside to connect it somehow, like to stay in place.
Okay, thank you. Let's go to the next question. That is from Ahmed Saleh, and that's a question for Dr. De Bruin. Why do you do radio frequency lesions and not go directly to surgery, especially in the cingulum case? Can radiosurgery be a final solution for the patient, or just a diagnostic or prognostic procedure?
Okay, so in this patient, the electrodes were implanted, so you are already there, and then you have this opportunity to do this coagulation procedure, and you create a small scar. And so we use it also prognostically. If we see that the patient gets seizure-free, which is usually temporarily, then you have a good prognostic value whether your surgery is going to be successful. So that's how I see it, but maybe the surgeons can add comments.
Yes. Well, you have a lot of French papers coming out after the first publication, 2004, from Maguenot. Well, and the French colleagues, they are dividing patients in becoming seizure-free versus also the responder group. And the responder group, that's the group which will have more than 50% seizure reduction after thermocoagulation. And especially in this group, that is a prognostic good group to become seizure-free after an open surgery, after resection. And that's also our feeling. We are preparing at the moment a paper, and we see in this group, in the responder group, that you have a bigger chance becoming seizure-free than when you are not a responder. So it's indeed also a prognostic procedure. Okay, let me see. Another question from Turkmenistan. So we have an audience from far away, I see. Hello from Turkmenistan Pediatric Neurosurgery. My name is Sharif. For how long should we make drug investigation before surgery? So I think he means how long should you have children on anti-epileptic drugs before you do make the decision to go for surgery?
Well, the general rule is that you try 2 anti-epileptic drugs adequately, and then you consider it as refractory, and then you can evaluate whether they are a candidate. But what we see a lot is that there's a lot of impact of a drug giving side effects that sometimes parents cannot continue, although it helps for seizures. Internationally, I think the indications are also changing. For example, when you have a lesion, should you wait until patients become refractory, especially if it's outside of eloquent cortex? So the traditional indication is evolving, I think.
Maybe I can also add that, I mean, in children, as a difference from adults, there is an entity called catastrophic epilepsy, where you have like hundreds or thousands of seizures a day, and then those children you need to treat within sometimes within days or weeks, because they are like really crashing and just stopping in development. So there is no time to wait for long, so which is very different from adults. I think it's not, that entity does not exist in adults.
Exactly. Okay, hopefully well answered. The next question is from Byron Sandoval for Yugoslav. Congratulations. Have you compared the VarioGuide Precision with a conventional frame-based insertion technique like the Lexel frame or the robot?
Well, there are many studies that have compared different SCG implantation modalities, how to do it. There are papers that show some sub-millimeter precision at the entry and target points. Let's say there is this paper for Cardinale that shows 0.8 in the entry point using Renishaw robotics. The main argument not to do this at our department with the frame-based procedure is that it takes much more time, frame-based procedure, than what we have now. Our surgery is approximately 90 minutes for, let's say, 15 electrodes. So the thing is, you have to just exercise and to get a real nice flow. Regarding other comparisons, I think the best instrument is the one that you are used to it, to know how to do it, and to follow the track, to try to improve the precision.
Okay. I see Dirk van Roost had a second question, but that was more or less the same as the previous one. Well, then I see some questions coming up. One for Christian from an anonymous audience participant, Professor Dover. What is the VNS usage in your pediatric series? So vagal nerve stimulation.
Yeah, so with regard to temporal lobe epilepsy, vagus nerve stimulation does not play a role, I would say. Vagus nerve stimulation in our center is only reserved for patients with generalized epilepsy, where we in the end do not have a real clue where the seizures are coming from, and where we cannot offer a surgical option. So in these cases, and these are reserved for VNS implantations.
Other comments perhaps from the participants? All the same, Dr. De Bruin or Ivanovic, agree? Okay, thank you. Let's go on. There is a good question from Matthias Tomczyk again. Thank you for the great talks. One question for all panelists. Does patient age and potential for neuroplasticity influence your decision-making? For example, being a little more aggressive or favoring temporal lobe resection over selective hippocampectomy in younger patients. Christian, perhaps?
Yeah, so this is the gradient, the pivotal question around it. And I would say you can say there are two schools in the world, the ones that try to be as selective as possible, and the other ones that seem to be more pragmatic, if you want to. And the question is if a two-hit surgery is better than a one-hit. So if you have a child at 6 years of age and you do a selective resection, you resect less of the cortex, less of the brain. So in theory, this should be then be more favorable for the neuropsychological outcome. But in the end, we were unable to really measure that and to confirm that. And if the patients then return because of seizure recurrence, then you can say, okay, then come back and do the complete temporal lobe resection, as I showed you in the series from the University of Alberta, which then gives you a very good chance that you can end up with a seizure freedom again. But this needs to be discussed with patients and the whole team, that you go first for a selective one, and then if seizures recur at one point, then you can come back. You can always come back and do the more complete one. In terms of risk or complications, I don't see an additional risk just because it's a redo surgery. And also the numbers that we have from literature seem to be the same, that a redo surgery is not increasing our complication rate.
Yeah.
Christian, I have one question in that case. If you have done selective surgery and then there is recurrence of epilepsy, so do you perform SCEG then?
So
Do you know?
yeah. So if the indication was very clear, so for temporal lobe epilepsy, so hippocampal sclerosis, nothing else in the MRI from the temporal lobe or anywhere else, a clear clinical correlation to it, then we wouldn't do an SEG, because then we assume this is coming from the neocortex of the temporal pole and just go for a re-resection. And this brings us quite the same numbers as I've shown you in the series, that the vast majority of the children and the adults become seizure-free after this. And then if they're still not seizure-free, then you're dealing with, let's say, temporal plus epilepsy. And this is something different. And then, of course, you need to go for SEG.
Okay. Well, the next question is from Nikolai Tonchev. I would like to ask Dr. Ivanovic whether his technique with BrainLab is applicable with intraoperative CT outside the operational hall and then coming back to the OR, or isn't that compatible?
Auto-registration is not, because you can't move the patients all the way. We never try this. But if you have a mobile CT scan, which there are some producers that they have it, I think BrainLab is one of these, and there is something called Aero. So you can use it on regular OR, but you have to have a mobile CT scan. So in that case, you can make the registration at the same place, let's say, where you do the surgery. The other option, if you would, let's say, have several bone fiducials and you take before surgery one CT scan, then you can move the patient up to the OR, and then you can register patient on these bone fiducials. And that could give you a good accuracy, I think, in registration.
Okay. Next question for Christian from Dirk van Roost from Belgium. The typical hippocampal sclerosis epilepsy manifests itself not at pediatric, but at late adolescence or adult age, while temporal lobe epilepsy in children is of a different origin, more dysplasia, migration disorders. Is this difference not the main reason why selective hippocampectomy is not as successful in children as it is in adults.
Yeah, fully agree with this notion. So in children, the issue of dual pathology is much more prevalent than in adults, for sure. But still, there are children with a pure hippocampal sclerosis and nothing else in the temporal lobe, where if you select them and see them, a selective resection can lead to a very good seizure outcome as in adults. But this is, let's say, much more rarely being the case, because in children, there comes also, if there's very small children, you need to address the differences coming from the MRI signal itself because of the myelination process. So many things that you see that you cannot see at a very young age become more prevalent at older age. So if you are misguided by not seeing any pathology in the temporal pole at a very young age, you may end up seeing that later. But I fully agree, in children, the incidence of cortical dysplasia in the temporal lobe is much higher than in adults, and this is also the one major cause why many centers around the world are doing anterotemporal lobectomy, as I showed you. But still, if you are a believer, let's put it like this, in selective resections, there are indications for it.
Next question. I think it's an easy question. Samuel Limos is asking, what role do you anticipate for responsive neurostimulation? Would it be a good addition to treatments and also to better localization of epilepsy? I think all of you can answer. So RNS is not available in Europe, but would it have a role? I think in selected cases it could have a role. So
yeah, it's like DBS in Europe or VNS. They are seeing a 50% reduction in 50% of the patients.
Exactly.
I know that some centers in the US, they actually use hippocampal RNS as the first line treatment for temporal lobe epilepsy, because there is a lower risk of cognitive deficit. And if that does not work, then they go to LIT. And if it doesn't work, then they go to surgery. So I think at least in that setting, which of course might be different for a number of reasons from the European setting, it seems that it has a really large impact. And they, especially for the left-sided hippocampal sclerosis, that's become quite popular with RNS.
Right. It's as I said, in the US, open resections are literally dying, but this is influenced by many factors, also economical and these kind of things. The whole framework of the healthcare there that's influences this drive.
Such a pity that there is no randomized studies when they introduce these techniques. It's the same with LIT. There are no randomized studies, and they would be, of course, the perfect way to do it. I mean, but we just made a meta-analysis of the LIT for temporal lobe epilepsy, comparing that with ATL and SAH, and I mean, in short, the number of seizure-free in temporal lobe resection is about 70%, whereas in after LIT it's about 55%, which are seizure-free, which is quite a difference. But still, many people are happy with either being seizure-free or almost seizure-free. There are fewer seizures, and they don't want to do the big operation. So
yeah, all arguments are true. And in addition to what Christian was telling, so I think the healthcare finance systems are totally different. You cannot compare the States and Europe. And another thing is that you see that in many countries, LIT is coming up, but there are no cost-effective studies. So effectiveness, perhaps yes, but cost effectiveness or economic evaluation, because the catheters of those lid treatments are very expensive, over $13,000. And you also could say, wait a bit with it, and let's see what comes out in the high volume center doing lid with outcome, and perhaps they also do a kind of economic or cost evaluation, and then the starting centers can see if this is good for them or not. Exactly, there is a last question. I think it's from an Asian colleague, Cheng Chai Yeu. I hope I pronounce it well. Lid would be a very selective lesioning procedure. So maybe it wouldn't be so recommended in pediatric cases, since the epilepsy outcome results are likely to be worse compared to temporal lobectomy.
Right. I agree, but still it's done. And so I lost my track. But yeah, that's what I wanted to say. So there are many patients also in Europe that do not want to have an open resection. They are very fearful for different reasons. Let's cultural reason, what they have heard about epilepsy surgery. And there's a treatment gap of patients that may consent to a lid procedure. And if we are able to treat those patients that would not allow for open resection with a lid, then that's fine, because it is at least it has some good effects in many patients. So for this treatment gap, I would say it's a good thing.
I think we would rather use lid for a little bit more difficult cases like hypothalamus hamartomas or periventricular nodulus and some of these medial aspects of the brain. So these are a little bit better indication than directly go for selective procedures on hippocampus, I think.
Yeah,
I can just chip in. I have one child which is 15 years who was treated with LIT for a medial temporal uncle tumor, which was a pilocytic astrocytoma, which caused him epilepsy. He was absolutely didn't want surgery. So we took a biopsy from it and made a LIT, and he's seizure free. So I think that LIT can be a tool when you have patients that don't want surgery for a number of reasons, or if you want to, for some other reason, really go with a lower risk. But I agree that in general, for a medial temporal lobe epilepsy in a child, I would not do LIT. I would do an open resection. Whereas for an adult, I would consider LIT.
Yes. I myself have a question for Yugoslav. So you talked about the entry bleedings. So I suppose you think of venous bleedings there. You also do a CT venogram. What is your technique of perforating the dura? Do you use this monopolar coagulation probe where you make a small hole in the dura and then introduce the stylet for the before you introduce the electrodes, or do you make a kind of sharp hole in the dura with the stylet directly? I ask this because I spoke to Jorge Gonzalez a couple of times, and he has a theory that is, I think it's not published yet, but he told me in the adult group, not in the pediatric group, but in the adult group, he also is more anxious for surface bleedings, venous bleedings, than arterial bleedings in the depth. And for this reason, he is not doing any more a monopolar coagulation of the dura, because then the dura will shrink a bit and potential veins, cortical veins, or some vessels in the dura come closer to your your entry point, and that could then be a reason that you have a venous bleeding. But I asked him, okay, what is your alternative? Because this is the official technique. And then he told me, well, I make a small hole by pressing my stylet in the dura and then introducing the electrodes. After which I asked him, okay, are you not more anxious when you are doing that, of having an epidural hematoma. And then he told me, well, I never had one. So this is a bit open discussion. What is your view? What is your opinion about this?
Well, I was at Cleveland Clinic and discussed this with Jorge, and he told me at that time in 2016 that he is not doing coagulation of dura anymore. But when we do our surgery, of course, you can penetrate dura with twist drill. This is one option. Then the problem is solved. Let's say you may get another one. And I do almost always coagulation on dural surface, because to press something like stylet through dura, I don't feel confident with this, and I'm not sure if I'm going to point to the same point with electrode later on. The second thing is you have to penetrate dura, and then you have to penetrate p-arachnoidal surface. And with this electrode and coagulation, you open the dura and you do small corticotomy. So what I try to avoid is, if it is possible, in these more eloquent areas of the brain, not to do coagulation, because if I induce some problems, so it can be reflected by neurological deficit, let's say. In general, so always we test first with 2 to 3 millimeters depth of electrode, of coagulation electrode, if it went through dura. If it did, so I don't have to burn. If it didn't, I have to burn. This is my workflow.
Great. Okay. Well, I don't see any more questions. We are almost 6:30, so very good time schedule. I saw in the panel list that we had 125 participants all over the world from, I think, 4 continents. So that is quite good. I hope all questions were answered. I would like to thank very much the lecturers, Gwendoline de Bruin, Jugoslav Ivanovic, and Christian Dover for your beautiful lectures.
Yeah, really nice lectures, I think. Very, very clear and
appreciate that. Also in the chat box. I would like to thank Daniel, of course, for co-chairing this session with me. And of course, Radek, as the co-chair of the pediatric section, for helping organize this good webinar.
We thank you, Olaf.
Thank you very much.
Okay.
My pleasure.
Thank you. Thank you.
Very much.
Bye-bye.
Goodbye.